Hello, thank you again. Thank you for joining us. My name is Elizabeth Rodas, and I'm going to be talking about the sensory systems and dementia. For a quick outline of what we're going to be going over, I'm going to just go over the definition of dementia. Exactly what is it, just as a reminder. We're going to do a little bit of a neuroanatomy review or summary. We're going to talk about the sensory systems and some of the most recent evidence and research that's being done in the field. And then I'm going to shift gears from a researcher to more of a therapist and put on my clinical hat a little bit and give you some practical tips on things that you can do in the home environment that can really help in being a caregiver. And we'll talk about a couple of examples. So when we say dementia, what exactly are we talking about? Dementia is a cluster or a group of diseases and syndromes. So it's actually just a condition or just a general term. We considered it this umbrella term of a loss of function related to losing your memory, judgment, language, motor skills or movement, the ability to have that executive functioning with higher level problem solving and things like that. And it's at the result of permanent damage to the brain cells and neurons within the brain. So there's several diseases specifically under the dementia umbrella. The four most common types are Alzheimer's disease, vascular dementia, Lewy bodies, and frontotemporal lobe dementia. With that, I'm going to go back and forth for just a second. I hope it doesn't confuse you too much, but I'm going to show you just what a general brain looks like. These are the general functions of a strong, healthy brain. So someone without a whole lot of disease is going to have a strong frontal lobe, and that's planning with your thinking and ability to anticipate the environment and make quick decisions, things like that. You have people with Okay, I'm sorry. This area in the middle is going to be able to predict your movement and things like that. We have another area that they say is pretty dominant for sensory processing, but we're gonna question that in just a minute. And we have a couple other areas. It's interesting to note that this whole occipital lobe is devoted to vision. So this is the highest level of brain surface area for any given sensory system. Vision is really important. And the temporal lobe has to do with hearing. So healthy brain, right? And I'd mentioned those four most common types. So I'm going to show you what they look like from a pathology standpoint. This top one is general Alzheimer's disease. This is what happens when someone has later stages of Alzheimer's disease. It's just a general atrophy or shrinking of the entire brain. The cells die and the brain gets smaller. So all areas are impacted in those several different regions that I just showed you. This picture down here, this is a Lewy body. So in Lewy body dementia, you have lots of different deposits of these little proteins right here. And once they're deposited, they're kind of like a boulder in the middle of a highway. So if you consider a message going throughout the brain and you hit this Lewy body, it just gets blocked. It can't keep going to the next pathway in the brain. There are some tricky ways that we can work around those, but that's also really challenging and has some characteristics of really strong symptomology as well. This picture here shows you general aging of a normal brain, and the two images on the bottom show vascular dementia. So if someone has repeated strokes or if they have a lot of vascular problems regarding blood flow within the brain, that tissue starts to scar and die off. And so that area of the brain, whatever it controlled, now isn't working very well or at all. And the last most common type is the frontotemporal lobe dementia. And I just mentioned that frontal lobe is the executive functioning and problem solving and planning of your day, controlling what you say, that kind of thing. So this type actually has a lot of really challenging behaviors associated with it. It's an area that I talk about behavioral management a lot. So if you have additional questions later after this presentation, please feel free to jot down my contact information and we can talk more about that. All right, so we have our brain set, right? We have a healthy brain and we know what our regions do. We now have images of what this dementia kind of looks like within the brain. Now I want to talk about how we interact with that brain. When we consider the environment, We think about our house, we think about a park, we think about walking outside, but we don't usually think about how those messages are taken into our body and what our brain does with it, right? So we commonly talk about the five common sensations of vision, which is sight, auditory stimulation, which is sound, smell, which is olfaction, taste, which is gustatory stimulation. Those are and touch, that's tactile. So those are the five common. Within a therapy realm, we also consider pressure. So this is called proprioceptive input, and it has some really strong therapeutic qualities. And I love proprioceptive input. If you think about ever going to a deep pressure massage, when you go get a pedicure and they're giving you that massage on your feet, that's proprioceptive input. It feels really nice to our nervous system. Movement is another one, and that's characterized as vestibular stimulation. And interoception is increasingly known in the literature, and it's talked about more and more. But this is how you know how you feel on the inside. So it's the sensation of pain, or I'm hungry, or I need to go to the bathroom. It's sensation from the inside of the body. I'm going to try an audience participation. This is the first time I've done this. I saw it yesterday in another presentation, and I emailed the author and I asked to borrow it, but I thought it was pretty cool. So follow along if you want. On the next 3 slides, I'm going to show you a series of photos. If you recognize the person in the photo, yell out their name as quickly as you can. You can unmute, you can do it muted, however you prefer. And I will say that the activity was borrowed from Dr. Heather Whitson at Duke University. Are you ready?
Bill Gates.
Bill Gates.
Serena Williams.
Serena Williams.
Williams.
Barack Obama.
Obama.
Great. So what did we just do? We just maximized your brain. So we used our eyes. That goes into our ocular nerve. It shoots that image through the thalamus and the midbrain right through here to process and categorize that information. It puts that image back in this occipital lobe, and then it shoots it back. It sends it back to your limbic system. If you have any kind of strong feeling about any of those images, that's going to kind of come up. You're then going to maximize and go up to the motor system, or the motor cortex, which is up top, because I asked you to talk. And then as people are talking, you're also listening to what others say. So if you didn't get it within that first second, you're going to hear what other people are saying and say, oh yeah, that looks like, Bill Gates. So we just went through that entire brain loop within seconds. So I'm good job. I love this kind of work and how we can use and understand the brain through a sensory system. So in that healthy brain that I showed you in all these different lobes, this image is putting on another layer of sensory processing on top of that. So each area has a designated spot. I'm going to use that word loosely because I love neuroplasticity. And neuroplasticity says that if we have a damaged part of our brain, we can start to use other parts of our brain that aren't typically used. That's fluid. It's kind of complicated, but I'm going to just use that word loosely. So we already mentioned that the occipital lobe in the back, that green area is your visual cortex. Semantic sensory association has to do with your body and things like that. The primary sensory cortex is historically what it's known for. It's just the primary area, but again, there's more and more literature showing that we're really maximizing the entire brain with sensory processing and sensory information. I also asked you to talk. So this little orange area right here, you also use this ability to produce speech and know what the words are coming out and things like that. So if we're thinking about sensory processing with typical people, there's lots of different things that we use to maximize our own well-being as caregivers and adults. That's great. But there's increasing literature that's coming out, and this was just presented a couple months ago in a presentation out of the University of Chicago. And they're looking at global sensory loss and the impact of all of these sensory systems together. So I will preface in saying that There are lots of different studies regarding vision and auditory stimulation and how that relates to cognition. There's more and more connecting the two and saying dual sensory loss. If you have loss in both of those areas, you're more likely to have sensory impairment. I'm going to take that a step further and show you some evidence and some things of having global sensory impairment and what that does. So the group out in Chicago did tests for 5 different areas. They looked at the accuracy and the ability of taste, touch, smell, vision, and hearing, the 5 most common. And what they found was that there was a significant amount of people that had impairment in all 5 areas, especially with aging. So we know that from this, that as you get older, we have increased impairment in any given of our sensory systems. It's just kind of how it is. And I mean, you guys probably know that as we get older, we get hearing aids and glasses and things like that. This is just a nice representation showing all 5 senses get worse as you age. So what does that mean? What does that mean? And what does that have to do with cognitive impairment? In 2017, I believe it was, the National Institute on Aging had a joint conference with the American Geriatric Society, and they looked at nothing other than sensory impairment. This entire conference was how sensory impairment impacts cognition. And they didn't come up with a whole lot of specific concrete answers, but they did start giving us a framework on what to understand and what to kind of look out for. So we know that sensory impairments are going to impact the cognitive load. And so what that means is that if I'm talking and someone else is talking and your TV is on, and you have bright flashing lights and your chair is vibrating, your cognitive load at that point is going to be pretty high. There's going to be lots of competing information coming into your brain. They also were talking about sensory function, like the functional networks in the brain structure, which is what I just showed you with those pictures and how your brain connects really fast to all those different areas. Depression also comes into play, social isolation, and reduced activity. If you can't see, you're less likely to engage in and participate in activities that you can't see. I remember as an occupational therapist, I was working with I had a referral for a participant or a client for not feeding herself. And that was one of the requirements to live at the facility that she was in, was that she had to feed herself. So the first day I did a quick visual assessment. She had a definition of, or a diagnosis of legal blindness, and she had glasses to help her see, but the care staff weren't putting her glasses on during mealtime. So that was kind of an easy, quick fix. I stayed with her for a few weeks to help her readjust to having her glasses, and she started feeding herself again. So it's just really important that we're paying attention to our sensory systems to help maintain engagement and activity. And the evidence is showing that all of these are connected to cognitive functioning. And looking at, and this is also out of that work out of the University of Chicago, and looking at this idea of global sensory impairment, they went ahead and did some longitudinal studies, and they assessed function, and their findings were kind of a little bit frightening. What they found was when people have global sensory impairment, and this is a sensory impairment of 2 or greater, that people had slower times of walking, they had more disabilities in their independent activities of daily living. So that's like grocery shopping, finances, driving, those higher level tasks beyond bathing, dressing, but things that you have to do as an independent adult. They also found that people have less activity from a movement standpoint. They have worse cognitive function, overall health, more weight loss, and increased mortality. So if the sensory system can impact this much, we really need to be talking about it more, and we really need to be doing some hands-on things to try to overcome that. If you think about the lived experience of aging with cognitive impairment or dementia, what does it feel like to age with dementia and cognitive impairment? Well, when we talk about feelings, it's all about sensory stimulation, right? That's how we feel things and understand the world in our environment. So I say this not to scare you, not to be a Debbie Downer, but just to give you a nice understanding of the impact of what sensory stimulation and sensory input can have on the body. Also, in a continuation from that work that they did at the University of Chicago, I am going to talk about this quickly, but I do think it's important to note that when people had 3 to 4 impaired sensory systems, they were at a significantly greater likelihood of passing away and mortality. So these are mortality rates. If someone with cognitive impairment or dementia, I think this is without dementia. It says dementia free. I'm sorry, I'm mixing it up a little bit. So without cognitive impairment, but with impaired sensory inputs, you're also at a much more likelihood of having mortality and earlier death related to your function and things like that. I muddied that up a little bit. All I'm trying to say is that with the number of impaired sensory systems going up, you're more likely to pass away out of any given results or causes. So that's a little bit of the bad news first. I'm now going to go into the good news and the things that I really like to do as a clinician, as an occupational therapist, and what my research is hoping to move forward in the field. I'm going to break down each one of these sensory systems except interoception, and I'm going to talk about some specific strategies that you all can apply at home as caregivers. When we're talking about, check the time really fast, as we're talking about sight, there's a couple tidbits or practical pieces of information. When people have advancing cognitive impairment, the color awareness fades. That means that the contrast of colors isn't going to be as high. And reds and greens have been known to stand out. So in those people that I get a referral for not eating very much, I often will recommend a red plate and put their food on that red plate because that red is a stimulating color, or a red cup to drink out of if people are not having as much intake. It's a nice option. Another thing that I would do with these reds is I would take duct tape. I'd keep duct tape in my work bag. And anytime I'd go into someone's house and I would be talking to a caregiver and they'd say, well, they never use their walker, or they can't remember to hold on to their walker, or every time they sit down on the toilet, they don't hold on to the grab bar. Well, maybe that's because they aren't seeing it very well. So I would put a couple bands of that red duct tape, kind of like a candy cane, right where I wanted their hands to be on the walker or the grab bar or whatever it was. And I would help train them that this is the sensory cue of this color. This is exactly where I want your hands to be. And it seemed to really help people start engaging and holding on to those areas. It helps people with dementia be able to predict and understand their environment a little bit better in order to do these tasks like bathing and dressing and things like that. Another thing that happens, and this is something that Teepa Snow talks a lot about, is that the visual field actually changes. So people have a tendency that we know that the peripherals start to shrink. So we end up with about a 12 to 24 inch peripheral. So things on the sides, you just don't perceive them if you have advanced dementia. This is important if you're a caregiver, that you don't want to walk up next to someone because you can startle them and you might, knock them off of balance with their startle. So anytime I'm working with someone, I always try to take a really wide stance and then come at them from the front so they can anticipate me coming. And as people age, they kind of hunch down like this, right? And so they have a tendency to look at the floor. And that reminder of, hey, there's other things in the environment, I should look up and look around my environment, it goes away. So people have a tendency to not really look up over 48 inches off of the floor in front of them. So we have this narrowed stance that we're looking directly in front of us at the floor. It's important as caregivers to know that if we hang TVs on the wall up high, people probably won't be watching very often. And that goes with any other thing. Depth awareness and dark colors, depth awareness goes away and fades. So that's really important if you're walking with someone out in the environment or going to a doctor's appointment and there's a step or a change in the threshold in the floor, that we're giving people verbal cues and kind of holding on to them maybe a little bit tighter because they're less likely to see those divots and changes in the surface of the floor. The dark colors also start to look like holes and shadows can look like holes in the ground. I remember I was working with a participant and he was living at a dementia facility and they had this beautiful carpet on the floor, but it had really dark patterns. And we were just trying to take a long walk and get some exercise. And he would keep taking his walker and he was kind of doing this in and out, almost like a slalom when you're skiing. And it took me a minute, and then I looked down at the carpet, and that he was following the light pattern on the floor around the dark pattern. And we know that the dark holes, or the dark colors, do look like holes for this population. So pay attention to the coloring on the floor and things like that. This is kind of just a general tip that pictures often can help with verbal communication and memories and things like that. So if you have pictures that people are fond of, make sure that those are out and people can flip through those. So that's several different tips for sight and vision. I'm going to switch gears and talk about sound and auditory stimulation. I have a tendency to talk really fast. I have a lot of emotion and inflection, I go up and down in my pitch a lot in my voice. And I have had to learn when I'm talking to people with dementia to slow down my breathing, to take long pauses, and to talk slower. It can take someone with dementia up to 90 seconds to process what you say. 90 seconds is an uncomfortably long time to sit there and wait for someone's response. There's also some thoughts that people only are really picking up 1 out of every 3 words that you're saying. So if I go in and I'm talking really fast and I'm really energetic, I can really just get on somebody's nerves if they're not processing what I'm hearing very well, and they're not understanding what I'm saying, and they just kind of push me off like a small chipping dog. You know what I mean? So it's important that we recognize that as caregivers, and that we don't anticipate an immediate response. There's been time and time again that I go into situations and I have caregivers, tell me, well, they can't stand up. They won't stand up. They can't stand up. And I watch the situation and I ask the caregiver to show me how they're doing it. And they say, Paul, stand up. Paul doesn't move for just a second. Paul, stand up. He still doesn't move. Paul, stand up. And on that 3rd time, they go in to help him stand up. And he kind of becomes agitated because it took that 3 times for him to actually understand what the person was saying. And he is fully functional and capable of standing up. He just needed a little extra time to process what they were saying, what they wanted him to do. I also really like music. Music sends endorphins throughout the entire brain. It helps it, get excited and light up. It also connects with the limbic system and emotion, and gets people excited, or it can help them calm down. So there is also some really interesting research that's showing that when caregivers sing, and it doesn't matter what they're singing, but just a melody during self-care activities, that the person with dementia actually participates and helps more in the activity than if the caregiver is quiet. So that means if it's time to get dressed in the morning and your loved one's name is Sally, you go in and you just start singing "You Are My Sunshine" to Sally. She's more likely to help you get dressed than if you weren't singing and if you were quiet. When we are thinking about music, genres do matter, and it is important that we're trying to encourage what people like. So there's this idea of the golden oldies and the golden years. That's the music that people listen to between 15 to 25. The music that you listen to in that age range is what you're going to like for the rest of your life. So when I'm teaching caregivers at facilities, I often say, the music that you like, that I like, isn't going to be the same as any of what our residents or participants or clients or patients, what they like. And that's the same as if you're married or if you're taking care of someone who's 10 years older than you. That might be a whole generation different of the music. If it's Frank Sinatra or Elvis Presley and the Beatles, that's significantly different. So pay attention to that. And I will just throw in this tidbit that I just picked up over the last year. I did a rotation at the VA, and I was presenting on something just like this. And I had somebody bring up the fact that during this age is when most people go, and veterans go into war, right? So if somebody was 19 and they had been listening to music right before they went into a military type fight or flying overseas or whatever it may be, it might elicit some really strong negative emotions and memories. So in understanding people's past, not just the type of music that they like, but the memories and things that were happening during this time period is also important. All right, so I got sound, we have vision. I'm going to talk to you a little bit about smell and taste. I'm going to put them together because they go hand in hand. If you can't smell, you can't taste. You can smell without tasting. It's a one-way street, but the perception of smell we know goes down with aging. We also know it goes down significantly with cognitive impairment. There's evidence, though, that there's the chemical reaction in the brain can still change behaviors. So I was reading some research that showed that they were using aromatherapy and diffusing lavender for people with dementia while they slept. So this means that they weren't alert and they weren't aware of the lavender, they were sleeping. And they showed that they had significant reduction in agitated behaviors the next day. So that also shows that these effects of the smell and the environment can last an entire day. So smell is really important, and it can do some different things. Lavender is, we know, is for calming. Citrus smells are alerting and exciting. So if it's about bedtime, there's lots of different things on the market now with lavender infused lotions and bubble bath and Epsom salts and things like that. You can get those anywhere. Citrus is another one that you might use in the morning when you're trying to wake people up and get them alert and moving a little bit more. Sugar is also a way, sugar and salt, but I tend to steer away from salt because of blood pressure and things like that. But sugar is a way to help people increase their intake. People typically like sugar, so if you have someone who's just not eating anything, sprinkling a little bit of sugar over their entire plate can help them continue to eat and consume that meal. Touch is probably one of my favorites. It's really interesting because we're really, really set on our personal preference. So I don't overly like to be touched. I don't really want people touching me. However, I am a very touchy person. I really like to touch people. And so when I'm working with my patients and clients, I always offer my hand. This is another Teepa Snow trick, to offer your hand open. The open hand actually releases endorphins. So it makes me feel calm because I'm welcoming people in. And it's natural for the person that you're offering an open hand to take your hand and put their hand in yours. So this is a nice opportunity for touch. Another thing with touch, I don't know if you've ever seen or heard of this idea of a homunculus. I think I said it right. Maybe I just butchered it. But it's this idea of touch perception is different throughout your body. So the input that you get in your fingertips is different than the input that you get on the side of your arm or your elbow. I don't have as many touch receptors here as I do in my fingertips. As people age, there's 4 areas that really stick out and are sensitive to touch. Your hands, your feet, your mouth, and your genitalia. So that's really important for caregivers as you're taking care of people from a sensory standpoint. If we're taking people to the bathroom or during showers, that we're cautious and we're aware of those 4 areas, that we're not overstimulating or really agitating the person. Not that we can't avoid those areas. We know that those areas are some of the most soiled and we have to take care of that. But coming at it with an empathetic idea of this person's probably going to be really sensitive to touch. We need to be cautious and try to prepare them as much as possible. I also often encourage people to touch the environment. And that sounds kind of weird. But if you think about a healthy adult, we're hands-on with everything. We touch our food and getting it in and out of the fridge. We touch different clothes to get ourselves dressed. We touch the towels as we're getting them folded and doing the laundry. Anything that's involved in our job or taking care of people, we're constantly touching. But as people continue to age, especially with cognitive impairment, their world gets smaller. The opportunity to touch a diverse amount of things in the environment goes down, and they're less likely to reach out. They lose initiation. Literally, the ability to initiate activity and things goes down. So their hands and this idea of touch really goes down. So from a person-to-person standpoint, I'm all about holding hands with people as much as you can. If you're taking care of your spouse, making sure that you're maintaining a close, loving, touching relationship. If you're a paid caregiver, making sure that you're aware of boundaries. We don't want to necessarily cross boundaries, but that we're not never ever touching the person that we're taking care of. and that we're continually encouraging them to reach out and touch different textures is really going to help the brain, and it's going to help that person feel a little bit better. All right, earlier I mentioned that pressure is my favorite. I don't like to be touched, but I do like a deep pressure massage. I think that this idea of proprioceptive input, there isn't much literature and research around it, but it's really strong calming input to the nervous system. If you think about a baby in the womb and growing, it's underwater, it's on constant pressure. And that's how your nervous system grows and develops the best and the fastest. It's this continual idea of once the baby's born, we know that one of the nice ways to calm down an infant nervous system that doesn't have any way to calm itself down is to swaddle this baby up. So they're in full body tight pressure, and it's calming to them. As kids, they're running and jumping and banging constantly. So they get lots of pressure in their joints. As adults, we're also, we're drawn to things like deep pressure massages and tight hugs and massage chairs that squeeze you, that kind of thing. It helps calm us down and relax us. Well, thinking about seniors who may or may not have some arthritis, and it's older adults with cognitive impairment who have less and less initiation to seek out natural touch or engage with their environment, they really lose a lot of opportunity to receive this proprioceptive input. I will tell you that proprioceptive input throughout your arms has the most impact in the body because we typically walk on our legs. That gives us some good joint pressure through our legs, but our arms don't get much, which means it is a little bit more powerful in our arms. So I often encourage caregivers, or if I'm the therapist, I will provide a massage to the hands, or if I'm going to give somebody a hug, just a nice tight squeeze for just a second. This picture is the hand over hand approach. I think this is another Teepa Snow tip or comment where you're putting that hand on top of their hand and you're giving them some light pressure. So it's just a nervous system signal to say, hey, I'm here. You can be calm. We're in a working relationship, and it's a safe space. There's another technique that we use a lot with kids with disabilities, joint compressions. We have to be careful with these if people have arthritis, but it's just this idea of offering input throughout the body, just like a swaddle would do to help the person calm down. There's more and more on the market, the weighted blankets. You guys might have heard of those. I think they're fantastic. You do, personally, as a therapist, you have to be careful that you're not giving anyone over 10% of their body weight, and that you actually only have a 20-minute window that you're going to have therapeutic effects. So after 20 minutes, people will start to habituate to this feeling of pressure, and they become less aware. And for our older adults with weaker muscles and thin skin, it can mean increased likelihood of joint damage and tissue damage if you lay that weight on there for too long. So if you were to apply a weighted blanket, don't use more than 10% of the body weight. Don't leave it on for longer than 20 minutes. Never put it over the chest or near the neck because it can be a strangulation risk. All right, movement, I think, is the last one that we're going to talk about for now. Movement is vestibular input, and it can be exciting and it can be calming. So I really like vestibular input and tied to exercise. So getting people up and dancing and moving your arms as much as possible is really going to help keep the body strong. It's going to be good energy for the brain to help it keep functioning and work on that balance system. Linear movement, so side to side or front to back, is calming. So rocking or swinging, some people will go side to side. That can also be calming. If your loved one is overwhelmed and you start to see them just kind of rock in their chair, sometimes that can be a signal that maybe they're overwhelmed. Maybe the environment's too loud. Maybe they need to go to the bathroom. Maybe there's something wrong. Is that a signal for me to help address their care? All right, I think that's it. I think that's what I got for these sensory systems for now. If you have questions, I'm happy to talk about them more. I'm going to go through a couple examples, checking our time again. As their care partner, I really want you guys to know that it's really important. Quality of life really matters for you and in the person that you're taking care So we want to encourage participation as much as possible. Again, that initiation goes down. So just because they aren't actively starting an activity doesn't mean that they don't want to participate. It means that their brain may not be getting the signals and have the ability to start on its own. Once you get somebody started in an activity, usually they can continue on their own, but they may need help to get started. I was talking to a renowned neuropsychologist yesterday out of Georgetown University, and he offered me this tip and said that we want to offer non-anxious presence when we're with other people with cognitive impairment. And I laughed and I said that, you know, I know the technical term, it's called emotional contagion. When I yawn, you yawn, right? If I'm anxious, you're going to also pick up on that same energy and you're going to become anxious. If I'm breathing really fast, you're going to breathe really fast. It's just this automatic mirror neuron network in our brain. It's literally, we mirror the people that we're close to. So if you think about this non-anxious presence, you know, even if I feel anxious inside, for the sake of the person I'm taking care of, can I take a deep breath? Can I slow my voice and be present in this moment right now to just be fully calm and comfortable with the person I'm taking care of? Because that person really does become your mirror. Use empathy rather than demands always. Just remember to slow down. That's something that I constantly have to remind myself, you know, 100 times a day when I'm working with someone. Slow down, slow down, slow down. As always, talk to your doctor if you have concerns regarding behaviors or changes in function. I have a couple examples. Terry, is it okay if I go through a couple more?
Yeah. These reminders are really great.
So I gave you all a whole lot of information about the brain, about some new research that's coming out with sensory input and sensory systems. Then I gave you some practical tips. So now I want to apply these in a couple examples. I had an example of someone who, this gentleman was absolutely refusing to take a shower. He just would not go. And so I had the referral for bathing, to help with bathing. I came into the situation and I realized that the bathroom floor and the bathroom walls were white. The shower stall was white. The shower bench was white. The shower curtain was white. The grab bars were white. It was a completely color voided situation. And actually sensory deprivation in that kind of situation can be used as punishment in some situations. So this was a signal to me as a therapist, is saying this environment is not set up for someone with cognitive impairment, with bad vision, and who's having someone give them a bath. It can be like a frightening waterboarding experience almost. You get your clothes ripped off and they can't anticipate the water coming at them. That's okay. It's something that we can fix. So I talked to the caregiver and I said, let's buy some red towels. So I had a red towel sitting on that white bench. I brought in my red duct tape and I put it all around the shower head and the grab bar. So now the person can see where they need to sit. They can see what they need to hold on to. I also put one strip right at the base of the shower threshold, so where they needed to step over to get into the shower. I also really like to encourage people to participate, even if it's not functional or effective. Just giving them the opportunity to participate will help them remember or remind them of what you're trying to do. So even if they're not going to wash themselves, handing them a washcloth so that they can engage in the activity while you're washing them down quickly or slowly, however you prefer to do it, and getting them clean, and they can say, oh yeah, I'm sitting in a shower, there's water, I'm going to help wash as much as I can. A couple other things. I was taught in OT school that if we're not sweating during a shower, the person that we're taking care of is cold. So warming up that environment in the bathroom, you know, if you have a space heater, you might be a little bit uncomfortable, but they don't have clothes on and they're not working to wash somebody off, so they might be cold. You can also throw the towels in the dryer before the shower. So a couple things, if people don't like to get undressed, you can wrap that warm towel around them as you're taking their clothes off. It's a little bit tricky, but it's effective because people like warm towels more than they like their dirty clothes. And as you're getting people out, you can wrap them up in that warm towel because that's going to help them. If they are agitated or upset during that bath, it's going to help them calm down and soothe pretty quickly. And again, sing or play music. I mentioned earlier a couple different tips for feeding, but just as a reminder, sometimes people have a hard time initiating. So if you set down this beautiful red plate of food right in front of somebody, you have their glasses on and they're completely prepared, and they still just stare at their food. Sometimes a hand over hand approach. So you're holding their hand, it's hard for me to show you with my hands, but if you're holding their hand gently, you help them stab that food on the fork and then slowly bring it up to their mouth. For 1 or 2 bites, you help them a little bit, but then you back away and you see if they're able to continue to feed themselves on their own, because autonomy is really important for participation at this stage. 2 more examples. If people are restless and wondering, it might be that they're bored. Their bodies literally might just need vestibular input, because it is regulating and calming to walk. It's this linear movement, right? So maybe rather than thinking or that automatic thought of, you know, they're up again, what are they doing? Maybe we should literally just go outside and take a walk and they won't wander as much, or throw on some music and do some dancing. And people really like routine. So routines are stored in the basal ganglia, which are in the base of the middle of the brain. So like way in the depths, right? And I showed you these pictures of the brain and how it atrophies on the outside, but it takes a long time for it to get right in the middle of the brain of this pathology. That means routines are stored for a really long time. It's this motor memory kind of thing. People will do the same thing that they've been doing for a long time. So the more that you can use routine and establish routine, the more you can have people participate and engage in their environment for as long as possible. I think that's all I have to present today. This is my favorite quote. I found it time and time again that people will forget what you said, people will forget what you did, but people will never forget forget how you made them feel. All right, thank you all for your time. I think we have a couple questions.